In this video, I'm going to explain about the acute subdural haematoma. In a previous video, I talked about chronic subdural haematoma. What is actually a subdural haematoma? To be able to understand this, we need to talk about the layers of the skull, or from the skull to the inside until you reach the brain. So you can find here, if we assume that this is the bone, so this is the bone with an outer cortex and an inner cortex on the inside. So basically on just the outer side of the bone, you will find the periosteum, and the periosteum is continuous to the inside with the periosteal layer of the meninges. And just under that, you will find the meningeal layer of the dura mater. So that was the periosteal layer, and then you will find the meningeal layer just below that. So this is the dura mater. Between them, there is a potential space, and this is the extradural space that can have an extradural hematoma. And just below that, just right there, it is subdural space or subdural hematoma. You go further in, and you will find that this is the arachnoid matter. Okay, and just to draw this accurately, let me just delete a bit of area here because basically the sinus will be sort of here, so that will be like that. Okay, and then you have the arachnoid matter going sort of like here with a space in between called the subdural space, and then you finally reach the brain just down there. There are some veins that are coming from the brain, and they're going all the way up to reach the dural venous sinuses, and they bridge between the arachnoid matter and the meningeal layer of the dura mater. So here they bridge, okay, and that's why they are called the bridging veins. And these bridging veins might disrupt and cause either an acute subdural hematoma or a chronic subdural hematoma. So the disruption of the bridging veins can happen due to trauma, and this will lead to the acceleration or deceleration movement, right? So acceleration and deceleration movement. If it happens, it's likely to happen in maybe slightly older age population, especially chronic subdural hematoma. And the reason why the brain atrophy happen with sort of older population, and the brain atrophy will start to shrink and will cause some tension on this bridging veins, and consequently they can lead to acute subdural hematoma initially. That can turn later on to a chronic subdural hematoma. So on a CT scan, an acute subdural hematoma, obviously it is acute, so that means it will appear to be hyperdense. So that's the first bit of it. So if you can classify it here, so it is called acute, and then it is a subdural, and thirdly, it's a hematoma. Okay, so hematoma, that means it's going to appear as a hyperdense or hypodense, right? Hyperdense or hypodense. On the other side, it is acute, so that means it's less than 3 days old, and it will definitely appear as hyperdense, white in color. It is subdural hematoma, and to be able to understand if this is subdural or not, on a CT scan, you will find that it will be crescentic in shape, and it also cross the suture line, and it doesn't cross the Fox syrup line. And to be able to understand this here, so it is a subdural hematoma, and we explained it here that the meningeal layer is continuous with the periosteal layer outside, or the periosteal layer is continuous with the periosteum on the outside, so in the suture lines. So if you have an extradural hematoma here, it will not cross these suture lines. But if it's a subdural hematoma, it will easily cross the suture lines. So first of all, the subdural hematoma, they do cross the suture line. 2, they are crescentic in shape. 3, and they never cross the Fox cerebri. And the reason why they don't cross the Fox cerebri, because this thick dura represent a physical barrier between one hemisphere and the other hemisphere. All right, so to move on with our case, so we have a 20-year-old male patient presented with a road traffic accident on a very high speed. GCS on theme was initially 3, and pupils were equal and reacting. The patient was intubated, ventilated, and cervical spine was immobilized and had collar and blocks as well. GCS remained 3, and pupils were 5 millimeter in diameter. So the pupils are currently getting bigger and bigger, and now they are unequal pupils. All right. So now you're worried about a 20-year-old with road traffic accident with GCS of 3 and unequal pupil. So what will be your management for this patient? Obviously, this is a polytrauma patient, so you will need to do a full A to E assessment for this patient, making sure their airway is patent and secure, and they're getting adequate oxygenation on breathing, and that will happen by giving them the adequate oxygen by starting high flow oxygen, etc., making sure their C-spine is secured as well, and for their circulation, make sure they have adequate IV lines and being started on fluid resuscitation. After you do the full A to E assessment, you will need to scan this patient, and the first scan you will do CT head, and of course do not forget that we'll need to rule out other injuries when you're doing the A to E approach. After doing CT head for this patient, you'll need to identify if there is any kind of hematoma or traumatic hemorrhage. Given that this patient pupil started to be unequal, so that suggests that this patient started to have an increased ICP. So we can start the medical management of an increased ICP. And that will be through putting the head up to 30 degrees and maybe starting them on mannitol and giving them ventilation and keeping the PaCO2 on the lower side, and that will be covered in a different area. What is the mechanism of action of mannitol? Mannitol is a hyperosmolar substance. It will usually create an osmotic gradient across the blood-brain barrier, and that will basically sort of suck the water from the brain. Looking at this CT scan, which we have presented early, you can see that this is an axial cut of a CT brain at the level of the lateral ventricles. You can appreciate that on the left side there is an acute subdural hematoma. Before saying that this is an acute subdural hematoma, you will find that you have a hyperdense lesion that is crescentic in shape and crossing the suture lines that looks like an acute subdural hematoma. It's causing mass effect, and this mass effect represented by effacement of the sulci, as you see here, and compression on the ventricles, and also midline shift. It's very important to try to measure this hematoma in millimeters and also measure the midline shift, because that will be relevant in the surgical planning, whether this patient needs surgery or not. All right, moving forward, can you explain why this is not an extradural hematoma? And we basically mentioned that you have bone and then the dura layer. It has 2 layers. One is the periosteal layer, continuous with the outside layer and very adherent to the suture line, and the second layer is called the meningeal layer, and after that you have the arachnoid matter, and in between the subdural space. Obviously, if you have a hematoma here, it will easily cross the suture line, but if you have a hematoma here, it will never cross the suture line. The extradural hematoma will be a lenticular or a lens shape, but the subdural hematoma will be basically a crescentic in shape on a CT scan. Okay, so this patient, both pupils started to be reactive after mannitol. GCS improved to 7, E1, V2, M4, and he flexes to pain with the left arm, but no movement is seen on the right side of the body. How his motor deficit is explained. So obviously you can see that this patient has a left pathology or left subdural hematoma that's causing compression. But you can appreciate here as well that it's quite far away from the motor area. So the symptoms here, or the sign that the patient is presented with, is not particularly cortical, but pyramidal in source. And this happens due to compression on the cerebral peduncle of the brain, and that consequently will lead to compression of the pyramidal tracts and will lead to signs of weakness. All right. So what is a definitive management in this case? A definitive management, given that it is more than 10 millimeter, and we're going to come to this, and also more than 5 millimeter midline shift. The best management will be doing a craniotomy / craniectomy, removing the bone and evacuating the hematoma. What are the practical steps that need to be taken to transfer this patient to your hospital, given that this patient is currently in one of the DGHs or the local hospitals around you? So first of all, you need to speak with the primary team looking after the patient. Make sure that this patient is currently safe and they had a full A to E approach and they are basically intubated locally to make sure that they are safe for transfer. We'll need to speak with the bed managers in both hospitals and arrange an ambulance for both of them. In your hospital, you will need to speak with the neuro ITU in addition to the theater team and your anesthetic colleague and also the on-call neurosurgeon to make sure that your team is ready for operating. The intensive care unit is currently full. What will be the options? The options will be trying to step down another patient to HDU from your ITU, or maybe using a general ITU, or using recovery or resuscitation in an ED. The patient has become hypotensive, about 75 to 40. How will this affect your decision before transferring this patient? All right. So although basically we do understand that this patient needs an urgent neurosurgical intervention, however, being hemodynamically stable will definitely affect their cardiorespiratory function and can lead to an arrest as well. So we need to make sure that they are safe and stabilized, and also they don't have any source of bleeding. They might have a systemic source of bleeding, and that's why they are hypotensive. So looking for other injuries as well. So after all, this patient underwent a craniectomy, as you can see here. So we have removed the bone flap, and you can appreciate that the midline shift has improved, and also there is a sort of an improvement of the sulci here. You can see some sulci, so there is no more effacement. So this is a post-operative scan. Midline shift has completely resolved. The bone flap has lifted out, so this is a craniectomy, and the patient should have a cranioplasty on a later date, maybe 3 or 4 months down the line. The factor that determine when the patient should be extubated, and this is an extremely important question that can happen after the surgery. Are you going to extubate this patient immediately after the surgery, or again, are you going to get an ICB monitor placed and then basically consider extubating on a later date? All right. So that will depend on the premorbid state of the patient, the nature of the injury, and also the effect of the surgery on the patient, and also secondary brain injury. So you'll find lots of controversies here. Some surgeons will prefer to extubate immediately after the operation and see what they do, and others will prefer to do it gradually. All right, so acute subdural hematoma can be managed still conservatively, all right, can be managed conservatively, and that will be based on, one, the clinical presentation, and 2, the imaging as well. Imaging, if it is less than 1 centimeter and less than 0.5 millimeter midline shift, in addition to the patient GCS is normal as well clinically, and it's improving, and they don't have any neurological deficit or being an elderly patient as well. Generally, the causes for subdural hematoma is traumatic. However, we can look into specific causes for traumatic subdural hematoma, and it could be due to accumulation of the parenchymal blood or the parenchymal laceration, especially in the frontal and temporal lobe. And the other thing which we mentioned earlier is damaging of the bridging veins, as we mentioned earlier. The mechanism of bleeding, we said in a younger population, high force leads to damaging of the bridging veins. You can see some scans here. So again, this is an axial cut CT scan. You can see a right-sided, hyperdense, crescenting in shape lesion that's causing mass effect, including midline shift and effacement of the ventricle, or compression in the ventricle and effacement of the sulci. And again, this is a hyperdense. That will be an acute subdural hematoma. So the next scan here, you can identify that this is a coronal scan on one side, and the other one is an axial cut CT scan. You can see a hyperdense lesions in the just around the fox cerebelli and also just above the tentorium cerebelli. So this is a falcine acute subdural hematoma. With this type of subdural hematoma, it can be a little bit more difficult to treat surgically, and conservative management is usually the option to go with, because as you can see, it's very deep down in the brain. However, you can also go around it and try to evacuate it. So basically, we identified 2 scans here. This is a right-sided acute subdural hematoma, and this is and also causing compression, and the compression represented by, or the mass effect represented by, compression on the ventricles, and also midline shift, and also compression of the ventricles, midline shift, and also effacement of the sulci. And this is called a falcine subdural hematoma. So when would you operate on patients with acute subdural hematoma? So first of all, you have an acute subdural hematoma on a scan, and clinically the patient, you're going to assess the patient GCS. But your management always starts from looking at the CT scan. So looking at the CT scan, you can tell about the thickness of the hematoma. So if it's more than 10 millimeter thickness, or the midline shift is more than 5 millimeter thickness, that's in itself is an indication for surgery. All right, is an indication for surgery. On the other side, if you can identify that the hematoma is less than 10 millimeter in the thickness, and there is midline shift that is less than 5 millimeter, and also the patient had a GCS drop by 2 points, that's clinically, or the pupils are asymmetric or fixed and dilated, or the ICP has been consistently above 20 millimeter mercury on the the ICP monitoring. So the management, the surgical management, can be solely be dependent on the CT scan. If it's more than 10 millimeter thickness and more than 5 millimeter midline shift. On the other side, what if it's less than that? If it's less than that, look at the patient clinically. If GCS is less than dropped by 2 points, you can consider surgery. And if the ICP monitoring is consistently more than 20 millimeter mercury, again, that's another indication for surgery. And finally, or the pupils appear asymmetric and dilated or fixed, you can consider surgery as well. What are the factors that should be considered prior to surgery? The factors are, first of all, looking at the patient anticoagulation, or if they have been on any kind of anticoagulant medication, and try to reverse that before taking them to theater, because that will, of course, increase the risk of bleeding. And also the location of the hematoma. Usually the convexity hematoma are less threatening than the temporal or parietal subdural hematoma, which are quite deep down in the brain. The interhemispheric or the falcine Subdural hematoma. So interhemispheric, it means subdural hematoma in the falx cerebri. Usually happens in children due to child abuse, maybe head trauma or ruptured aneurysm as well, especially the pericallosal aneurysm or the anterior communicating aneurysm, for instance, and also can happen spontaneously. Looking at the CT scan here, you can also identify this in axial cut CT scan, looking in interhemispheric acute subdural hematoma or falcine acute subdural hematoma. The management, if it's small and it is symptomatic, can be managed expectantly or conservatively, and the surgery should be considered if your patient has progressive neurological deterioration with a large lesion, and approaches would be usually through parasagittal convexity, parasagittal craniotomy, and the surgery of the lesion will be can be basically treacherous or can also lead to significant bleed as well. All right, and also there is a risk of venous infarction if you go with this pathway. So just to sum up, we talked about acute subdural hematoma. We had initially a young patient coming with road traffic accident. So your key is to identify the mechanism of injury and to recognize the serious issues here. And the serious issue is that this patient dropped GCS and also has unequal pupils. So you're thinking of something intracranial with increased intracranial pressure. You consider the medical treatment for an ICP, and you got a CT hit for the patient that showed an acute subdural hematoma on the left side, causing significant mass effect and midline shift more than 5 millimeter. So you thought about considering surgery for this patient, and you operated in this patient as well. And the post-op scan looks like that, with nice decompression that happened, and also the ventricles started to fill up again with less mass effect. You started to see the falci, the sulci, and also you thought about what are the factors that I'm going to extubate these patients, and the factors included many things, and one of them is the premorbid status and the nature of the injury, and also the effect of surgery on the patient. And acute subdural hematoma can be managed conservatively if the patient is clinically well and radiologically you have a small hematoma, and on the other side can be managed surgically if you have a hematoma that is more than 10 millimeter in thickness or more than 5 millimeter in the midline shift. On the other side, if this is not achieved, you can consider surgery if the patient had 2 points drop in GCS, are also asymmetric or fixed dilated pupil, and an ISP of 20 millimeter mercury. You think about anticoagulant medication, and also you can think about other injuries if the patient has any other injuries as well before the operation. And also you will think about the site of the hematoma in the surgical planning. We talked about the falcine acute subdural hematoma as well, and the treatment for that is pretty controversial. So that's acute subdural hematoma, and the previous video was about chronic subdural hematoma and its management. You can see pretty much straightforward. The surgical management for acute subdural hematoma is doing a craniotomy versus craniectomy. For chronic subdural hematoma, what you want to do burr hole evacuation of the chronic subdural hematoma, or very rarely mini craniotomy in certain cases. All right, thank you very much.